Hi, my name is Jim Plum, and I'm a family doctor by training. I was in one of the first classes of family medicine doctors. I won't tell you how many years ago, but we were going to change the course of American medicine with our approach to the family as a unit of care. And here we are 40 years later with many of the same problems that we were facing back in the mid-70s. So my career has been one of sort of changing with the circumstances which I found myself in practice. I spent some time in rural Pennsylvania as a family doctor and ended up working with lots of folks who were involved in substance use. I became medical director of a substance abuse unit at a local facility, and it became clear in talking to these men and women that the challenges they were facing were far and away more than I could handle myself, and that many of the health outcomes that they were experiencing were beyond the traditional medical care. I hearken back to the World Health Organization, which has sort of taken the lead internationally in looking at what we call the social determinants of health. And if I could summarize what I'm going to say in the next several minutes is why treat people without looking to see what's making them sick? And this was really drilled into me when I came back to Jefferson and was approached by a group of medical students who wanted to start a homeless care project and asked if I would be their faculty advisor. I said, sure, but we don't know anything about what's going on in the city of Philadelphia, and we need to find partners. And we ended up starting a homeless care project about now 27 years ago. And in talking to the men and women who we were seeing in the shelters, many of them were working one or two jobs, but having no safe home to go to, so would come to the shelter for the evening. And I began to think to myself, what's going on upstream here in this country that's causing so many people to have so many poor outcomes? As you're learning in this class, the U.S. ranks anywhere from 28th to 40th in health indices around the world, and we spend way more than our competing countries. We're not getting the outcomes that we deserve, and particularly that our public deserves. So we begin looking at what are those social determinants of health that are leading to these outcomes. And I would posit that the greatest in this country happens to be wealth inequality. And I call your attention, and I'll ask your professor to call attention to the work of Sir Michael Marmot, who recently wrote a book called The Health Gap, which makes a strong case for wealth inequality as being a major driver of health outcomes. We also need to look at food security, housing insecurity, education, and lack of jobs. And what the World Health Organization says is we really need to improve daily living conditions, both worldwide but in this country. Equity from the start, healthy places and healthy people, fair employment, decent work, social security throughout the lifespan, and universal health coverage. Many of those things, many of our citizens are not currently taking advantage of because of the system that's stacked against them. I also learned in working, we've had several projects in the Philadelphia prison system where the recidivism rate from folks who were released coming back in 6 months was near 50%. And if you think about the reasons why folks would rather go back to prison than be out on the street, there are many reasons, but one is it's safe, they felt secure, they had good food, and they got their medications. When they were discharged, they were sent home with 2 to 3 days worth of medications and a bus token. That's no way for a system to deal with an underserved population. So we've been working here in the city to try and ensure that folks, when they leave the prison system, have an appointment with primary care. If there are behavioral health issues, making sure they're plugged into the system, given transportation, and that there's a safe place for them to go that's not a bus, that's not a shelter, and certainly not the prison. So if you look at underserved populations, there are a lot of services. There's just a disconnect between what's available and what people trust. And trust become the major factor with folks who are vulnerable. They've been shortchanged by the system for a long time, and the medical system is just as much to blame. The Affordable Care Act certainly tried to address many of the issues around insurance and has made many positive steps, and you're going to hear more about that. It certainly gave folks an opportunity to get health insurance, which is necessary, but it's not sufficient to ensure a good health outcome. One needs insurance to get into the system, but it's all the things outside the system that makes for the challenges, particularly folks who have chronic conditions. Trying to manage chronic heart disease, hypertension, or diabetes is very challenging when you have so many other competing demands in one's life, like childcare, like transportation, like having an affordable place to get decent food, and then having the co-pays and so forth to get one's medication. So the Affordable Care Act gave folks a lot of the tools they needed, but it was complex. It remains complex. But I think it's made a significant difference, and going forward, we'll see where all that shakes out. So I consider myself a family doctor first, a public health practitioner second, and I think the two of those things have combined into a term that's called an upstreamist. And upstreamists make sure that folks that they're taking care of here on, for example, Jefferson's campus are getting the best care, but also looking upstream to see what might be going on in their lives that we need to take not advantage of, but understand and see if we can link folks to resources. The healthcare system is moving into this sort of population health management sphere, and it's really asking the system to look at what are those extra system factors that are leading to the outcomes. And the accountable care organizations and those sorts of things, the population health management teams that are working on, are really looking upstream into people's homes, into people's lives in a caring fashion to try and bring folks to a level playing field where there can be true health equity. Until we do that, we're going to be saddled with, again, high cost, poor outcomes, and poor comparisons with our friends across the world. So I ask you to check out a book called The Upstreamist. It's well worth reading. There's a parable in that book, or a parable on a YouTube, a TED Talk, where two folks are sitting on the riverbank and they see a child out in the middle of the river, and they swim out and they bring him to shore and they start a medical clinic to take care of this kid. Several more come down the pike. These two gentlemen start a medical school right on the banks of the river. Finally, somebody says, well, who's throwing people in the river upstream? We can take care of the kids that are coming down and do a hell of a job, but why aren't we upstream seeing why these kids are falling in the river? That's what I'm thinking about. And when we think about healthcare administration and we think about healthcare management, we have to be cognizant of what's going on upstream with the folks that we are taking care of in medical school, medical centers, hospitals, and so forth. And I think an upstreamist also has to look at laws and policy. All public health is public policy. And I use the example of smoking in this country and how over 50 years we finally reached the point where there are some laws and regulations that might affect the individual, or the individual might feel that it affects them, but we're really talking about what it's doing at a population level. Several years ago, I was asked to support the ban on secondhand smoke in restaurants here in Philadelphia. And if you look at the impact that secondhand smoke was having on the employees of that restaurant, particularly the women, it became apparent that through no fault of their own, they were working in a facility that was allowing smoking, but they were having higher rates of stroke, premature births, miscarriages, and so forth. So we took sort of the individual's freedom and said, it's affecting at a population level. We need to think about a rule or a law or a policy that impacts a greater number of people. We talk about the health impact pyramid. It's the laws and policies at the bottom of that pyramid that affect the largest number of people. Clear at the top, where I started training with clinical care, it affects the least number of people and is often the most expensive. So we've taken funding and devoted it way up to the top of that pyramid for individual care, when some of those funds should be redistributed in some fashion into the bottom of that pyramid, where the social determinants of health are actually impacting the lives of our citizens more than the medical care that I deliver, or that Jefferson delivers, or that LaSalle's training people for.